operating room professionals, we have the responsibility to ensure that the patients that are coming through us have the privilege of undergoing a surgical procedure and come out of it without any form of complication or whatsoever. Let me quickly start a very pertinent clinical scenario of of a particular patient experience in my just a few days ago. There's this patient that came in as a case of preeclampsia, and this patient was operated upon, emergency cesarean section. Preeclampsia at 27 weeks, the patient is IUI, intrauterine termination, and at 27 weeks, presented in the hospital on referral from another facility as a case of preeclampsia. We operated this patient, but then of course a few days ago, that was about 2 weeks ago. Then a few days ago, the patient came in, was discharged from the hospital, and he has to come back for wound dressing. And believe me sincerely, this patient, came down with wound dehiscence, and the burden of coming to do the dressing, the costs, and of course so these are the components of we have the immediate component, of course, and the delay component of recovery after surgery. We want a situation where patients recover fast, without any complication or any form of burden on the patient. Now, I'll be using this slide. Permit me to use this slide, even though you wrote it's written perioperative care in nursing, but it covers everything that I'm going to talk about. And what it means is that for us to have a recovery after surgery, the management of that patient starts from the pre-operative phase. Of course, we're not going to neglect the pre-operative, the intraoperative events, and then of course, what happens at the post-operative phase, which is the post-anesthesia care units. At every stage, every member of the surgical team is involved in the management of this patient. However, so now we have a routine practice of assessment before surgery, the routine operating room activities in intraoperatively, and then of course the post-anesthesia care unit care, which of course already we have as a routine procedure. I'm going to take us through it. Now, the purpose of this conversation is for us, first of all, we want to reduce the stress response to surgery, and then of course we want to accelerate recovery. Most importantly, that's what the enhanced recovery after anesthesia is all about. And then of course, in the course of doing this, every member of the surgical team is involved in this process. We have the nurses, the dietitian, the physiotherapist, the pain management team, of course the anesthetist, the surgeon, of course the hospital management, and the quality control team. Now, when it comes to recovery after surgery, I'm going to be talking in terms of this following objective. Now, the most important thing is for patients you want to prepare the patient appropriately for the surgery, and then, professional communication among the handling professionals, safe perioperative practice and improve patient experience, and then of course improve on their practice and to ensure prompt recovery from anesthesia, and then of course from the effect of the stress of the surgery. Then of course, most importantly, the length of stay. We realize that over the time, there's a practice of long stay in the hospital. Now, let me take us to the past. Like I said, this slide is just a guide, but I have my presentation. I'll be going at the background with it. Now, if you cast our mind back, I don't know, I know we have audience from different locations, different perioperative experience, and outpatient outcome of care and all of that. But if you cast our mind back to the practice of, in the past or in the recent past, or maybe we're still doing it in our facility, you realize that most facilities, pre-operative prolonged fasting, mechanical bowel preparation, nasogastric tube, drainage tube, prolonged bed rest. These are some of the things that has happened in the previous past. When you want to, you are preparing the patient for surgery, and patient is staying, for a long period of time in the hospital after surgery. So these are some of the things we've seen. Patient is coming out of surgery with different wound drains, NG tube, and even before surgery, prolonged fasting and all of that. So these are some of the things that have been improved on in the recent past, and that has improved the outcome of the experience, in the operating room. Now, permit me to skip all the things. I'm sure we're all familiar with all of this definition of terms. Now, therapeutic care should improve patient experience, including quality of care and satisfaction with care. Improve health of population, including returning to home, work, and the quality of life, and reduce per capita cost of care through improving value. Now, you realize that, the cost of surgery around the world is usually very expensive. And that is not, as it is, you don't want patients to come back to the operating room, for a repeat as a result of iatrogenic injury, or maybe delay or any infraction in our processes and all of that. And so because of that, at every point in time, because of the cost of managing a patient for surgery, you are conscious of the fact that, you don't want this patient to undergo the same stress of, surgical procedure. You don't want them to undergo the same, most times I ask myself, who bear the cost? If, for example, patient have an infected implant surgery done, or patient had a complication from surgical procedure, and you have to go back to the surgery, who bear the cost? Most times, patients bear the cost. Now, when it comes to management of surgery, we have different phases of surgery. We have the pre, the intra, and of course, the three cardinal phases. We have the pre, the intra, and the post-op. And then, of course, different surgeries and classification of surgery. We have the emergency, we have the elective, we have the invasive and non-invasive, we have the minimally invasive. Of course, these are the typical example of a operating theater and their zoning. Now, preoperative preparation is very important. I'm not going to bore us with all of this. I'll quickly rush to enhance recovery. So this is, we're all familiar with this surgical safety checklist, which are the routine things we do, and of course, in the intraoperative phase, of course, the goal of and objective of management in intraoperative phases, you of course want to ensure asepsis, want to ensure that there's hemostasis, there's homeostasis as well, that the patient, whatever patient is taking in, the urine output, of course, is commensurate with whatever the patient is taking in. No negative fluid balance or positive fluid balance. The patient is not retaining fluid or is not dehydrated while in surgery. Of course, if there's any surgical risk classification for surgery, you already know that this patient require this special number of blood, and of course, they are prepared before you come in. So all of these things, come in during the preoperative preparation for this patient, and then of course, anesthesia, all of this, the safety, which is the duty of everybody. And of course, like mentioned earlier, the surgical team, which is involved in the assignment of ensuring that the patients, that come into the surgery, come out of surgery without any form of complication or any injury. Now, I've mentioned some of these things, these are positioning we use. And of course, we know safety is very important in ensuring those positioning, and of course, attentions are paid to the pressure areas and all of that. Now, this is a typical example, so we're all familiar with this kind of environment, and of course, now, transportation to post-anesthesia care unit, we want to ensure ventilation and perfusion, and then of course, design of a post-anesthesia care unit, and the proximity to, to the operating room. We said they are highly designed, and of course, they are designated staff that, ensure that, the safety of patient post-anesthesia is in. Then, of course, we know the purpose of PACU, that what we want to do, the PACU is the stopgap between.
Deji.
I can't hear you again.
I can't hear you.
It could be his network because I can't hear as well.
Sorry, what about now? Can you hear me now?
Yes, I can hear
we
you
can.
now.
Yeah.
Okay, all right, okay. I think I should just do without my earpiece. I think my earpiece is giving. All right, okay. So I'm actually on post anesthesia care units, and I mentioned I tried to talk about the essential things that will be done. The purpose of post anesthesia care unit, that when to ensure quick recovery from the effect of anesthesia. We want to reduce morbidity or mortality. We want to reduce length of stay. Produce quality services, of course, perioperative post-operative care, and reduce the cost of managing the patient as much as we can, by reducing any form of injury. So we pay attention to all of these things, knowing fully well that they contribute to the patient's outcome of care. And then, of course, before we move the patient from OR to PACU, these are some of the criteria that we look at. The patient must be conscious and weak, respond to stimuli, hemodynamically stable. Patient must be recovered from neuromuscular blockade, and then, of course, maintain oxygen saturation as much as possible. Then, of course, patient must be normothermic, before patient is moved to the recovery room. Now, this is a typical example of a recovery room. We said that in the first 15 minutes of patient in the recovery room, one-on-one nursing care is required. And then, of course, the next, subsequently, you can, the attention can be divided to other patients, while the patient is still in the recovery room. Basically, what we do in the recovery room is to ensure that the airway management, the basic life support, and the advanced cardiac life support, caring for acute surgical room. And of course, the drain, if there's any drain, we want to pay attention to this. Basically, post anesthesia care units is manned by nurses, but under the supervision of anesthesiology. So, typical example of a recovery room. And of course, we know the monitor, the multi-parameter. Seven parameters or even more at a go. For example, you can look at this one. This particular monitor can do heart rate, blood pressure, respiratory rate, non-invasive blood pressure. Some can also do invasive blood pressure monitor, enter CO2, temperature of the patient, mean arterial blood pressure and all of that. At a glance, you can actually capture, the ECG tracing. At a glance, you can capture the information about the patient, as patient is, of course, you are monitoring the fluid intake. And then, of course, defibrillator handy, nearby, and, state of the heart, Of course, in transporting patient to, of course, we want to ensure that, the trolley is one that can be adjustable, side rail, head hop, leg hop, you can assume a cardiac position at any point in time. And then, of course, a brake and all of that, just to ensure that patient safety is guaranteed. Let me quickly rush to my point, and that is recovery, enhanced recovery after anesthesia. Now, this is my point. Now, when it comes to enhanced recovery after surgery, we said that it's a multimodal perioperative care pathway designed to achieve early recovery for patients undergoing major surgery. And ERAS represents a paradigm shift in perioperative care in two ways. Number one, it re-examines traditional practice, replacing them with evidence-based best practices when necessary. And secondly, it is comprehensive in its scope, covering all areas of the patient journey through the surgical process. And the key factors that keep patients in the hospital after surgery include the need for parenteral analgesia, the need for intravenous fluid secondary to gut dysfunction, bed rest caused by lack of mobility, and all of that. So now, looking at this graph, looking at this image, I want us to look at it critically and appreciate what it is. And when we're talking about enhanced recovery after surgery, the guidelines covers every phases of perioperative care, and we have the pre, the intra, and the post operative. So what we're saying basically is that if a patient is going to have what's going to happen to the patient after the surgery start from even when you are admitting the patient for surgery, and that is number one. When it comes to pre-admission counseling, of course, let the patient be aware of what they expect. Psychologically, patient is prepared to go along the journey with you. Most times, some of these informations are not really passed, especially at the emergency situations when everything is, the attention is to save life. But in most cases, it's required that the patient, of course, the patient is conscious and alert and well-oriented to time, place, and person. That the patient is well carried along, especially neglecting for urgent surgery, and properly giving information of what to expect, especially at the post-op phase. This has helped over the time patients' level of cooperation, with the caregivers. Now, optimization of medical condition. Most cases, we realize that, maybe the patient is hypertensive, is diabetic, he has some maybe cardiac conditions, maybe coronary, acute coronary syndrome, or, coronary artery, disease, or cardiomyopathy. Or patient is suffering from one condition or the other, and the rush to do the surgery sometimes will prevent the surgical team to ensure that the patient is properly optimized before they bring for surgery. Most cases I found out, even as a nurse anesthetist, that we realize that most times surgeons are usually focus their attention on the surgical procedure. They probably most times are in a hurry to quickly put a knife on the skin. So the onus is on the anesthetist and probably any other member of the surgical team. Of course, the dietitian, I mentioned it earlier in the presentation, people that are involved in the surgical management of this patient to ensure that this patient is properly optimized before you present them for surgical procedure. Because in most cases, the surgery itself is a stressor to the body. And of course, the patient who is already, medically compromised, is the outcome might not be an experience, a desirable experience. Another major importance is, when it comes to web preparation, in the purpose of, so the new guideline is saying that we should avoid web preparation. In a situation where a patient is coming for surgery, fasting guideline has changed. Of course, the traditional fasting guideline don't patients should not eat. Situation where patient is coming for surgery maybe early in the morning by 8 o'clock and say, okay, patients will fast from 12 midnight till morning. So we said that, okay, it takes 2 hours for graded oral seed to completely absorb into the system. So most times, even this guideline says that you cannot even guarantee that the bowel is completely emptied, despite having to fast the patient all night. However, maybe in the process, probably you cannot even get a line, you are not rehydrating the patient. So this is even part where the nurses also come in, or maybe the dietitian is also coming in. Most times you are fasting the patient overnight, no rehydration, patient is not taking anything by mouth, and then patient goes into surgery without any form of rehydration. Of course, at this point, of course, really derange the body hemostasis and all of that, which of course is part of the thing I mentioned earlier in this presentation, as part of the things we do intra-op to maintain hemostasis and of course to maintain homeostasis. So in the patient that you have fasted all night, you bring the patient, that kind of patient, to the surgery, you are struggling to meet up with the body fluid volume and all of that. And of course, you might not be able to capture it very well, because of course this time around you are doing like an emergent rehydration of the patient. Meanwhile, something that could have taken time for the body to absorb and maintain that homeostasis, you have to be rushing it while you're in surgery, or maybe while you're in surgery, patient lost blood. All of these things are new guidelines that are coming up, and that involve everybody that is involved with the manager of patient coming for surgery, especially for theater team, perioperative team, to ensure that patient is not fasted unnecessarily. In fact, as a matter of fact, patients in the last workshop that I attended, where this was demonstrated, that even a 5 Alive drink can be given to the patient 2 hours before surgery, an adult patient, and about 100 meals can be given to the patient 2 hours before surgery, just to let the patient how you feel. Sometimes when you don't have anything in your mouth, it makes you feel like a sick person. So let the patient how they feel of having something in the mouth, and then of course rehydrating the body as well. Administration of non-opioid anesthesia. So one other thing we also do is that in an attempt to achieve maximum pain control, we bombard the patient with opioid anesthesia, which of course has its own systemic effect. The process, the patient's heart rate is cardiac function is depressed, respiratory is depressed, maybe the immune response is depressed, and of course, patient that was supposed to be up and the system that's supposed to be alive to the challenge of surgery is already depressed by the our intervention as caregiver. So we advocate that non-opioid anesthesia should be of an alternative to opioid anesthesia. However, in the intraoperative as well, of course, most times by the virtue of experience over the time, I've realized that protocol-based care cut across every team member is the best way to go, as against discretionary management of patient. Most kind, of course, you have to use your discretion, but same where some will like, this is my preference. Of course, everybody should have their preference. I'm not saying no preference, but of course, let there be a guideline. Like, okay, this is how step 1, 2, 3, 4, 5, 6. You see, let's encourage in our practices. Let's have a protocol. The perioperative has their protocol. The surgeon has a protocol. Anesthesia has a protocol, and that's where the WHO safety guideline come in. Before surgery, everybody is aware of what you are doing. The briefing, the debriefing. It helps a lot to coordinate the team together. And then, of course, on long run, patient at the receiving end is safe in our hand as a team member. However, preoperative fluid management as well, not over rehydrate or under rehydrate the patient. Ability to be able to coordinate just like I said, it will have started from the preoperative phase, when patient is not fasted unnecessarily, and then a bowel preparation is not excessive to the point that patient has lost maybe some body electrolytes, and then you are trying to catch up intraoperatively. And then, of course, in most cases, you might not be able to capture the actual volume versus solute, solution versus solute and solvent solute balance. And at the end of the day, it's going to affect the patient's recovery from anesthesia or from even the effect of the surgery. So these are some of the things that's been identified over the time. So thromboembolism prophylaxis, venous thromboembolism events happens to patients who, of course, patient maybe before surgery, patients already bedridden, already are confined to bed and all of that. So, prophylaxis and sometimes non-pharmacological approach can be of help because for some reason, some of these might not be able to, heparin, for example, which is long-acting, or maybe NSAID, patients, aspirin, some of these medications has, the bleeding diathesis tendency. And if it is not properly planned at the preoperative phase, it will affect the intraoperative event. Antibiotic prophylaxis is very important. Maximum of about 30 minutes before the surgical incision, to prevent surgical site infection. I just told us about the personal experience of a patient who, after came in for surgery, emergency surgery as a result of preeclampsia, eventually has to go back again because of injury to the bowel, and then had to surgery only for eventually, at the end of the day, was discharged with wound dehiscent. This is a place of both iatrogenic and, of course, maybe perioperative antibiotics management plan, which might not be optimum enough to cover for the patient antibiotic therapy and all of that. So minimally invasive has also taken over extensive open surgery that probably will expose the patient more to ambient injury and all of that. Of course, prolonged patient stay post-operatively. Avoid intraoperative drains. If you can ensure that blood hemostasis is properly maintained intraoperatively, you might not need to put drains. And because putting drains is also immunocompromised, immunosuppressive, because the patient is predisposed to foreign bodies and external gadgets that might also be a vector for infection even to this patient, and of course drop the patient's body immune response to stress and all of that. Then avoid routine use of NG tubes. This is part of the drains that sometimes. So if you have ensured everything is properly done while you are in the internal structure of the patient, you might avoid the use of some of these things because of overburdening effects at the end of the day. Prevent hypothermia as much as possible. Hypothermia prolong the effect of anesthesia, and then of course even drop the immune response to body immune response to injury or infection or stress of the surgery itself. Multimodal approach to post-operative nausea and vomiting. You find that most times, there are multimodal approach to management of post-operative nausea and vomiting, even without use of NG tube and all of that. So these are some of the new guidelines. And then lastly, I'm going to be talking lastly on post-operative care. We are encouraged that patients, if you are not doing bowel surgery, patients should be encouraged to start early oral intake. Not necessarily that it has to be delayed, for before use. So that way, and as well, early ambulation will prevent the patient from, coming down with any venous thromboembolism event, as quickly as possible. Start the patient on oral, convert medications to oral. Remove urinary catheter as quickly as possible. Otherwise, you might be calling for catheter-associated urinary tract infection. Stimulate gut motility as quickly as possible. And by so doing, of course, you encourage the patient to start taking something by mouth, especially if you're not doing bowel surgery. That might be absolutely contraindicated. But in the absence of that, you are doing extraperitoneal surgery. You don't have to put the patient down. And then, I remember, I don't know if many of us remember those days when we were used to do cesarean section in this part of the world, especially in Nigeria. I remember when we were coming into the practice, if you do CS, 5 days, you are still in bed. They will not allow you to eat food. So we're saying that, that practice is obsolete. Let patients, it's extra intestinal procedure. That shouldn't call for patient being delayed down. You now be giving petazocine day 1, day 2, day 3. Patient is down. The patient is sick. Meanwhile, it's medication you are giving to the patient that is making the patient to go down. So non-opioid oral anesthesia as quickly as possible. Optimize glycemic control with insulin. If the patient is diabetic, ensure that your sliding scale or GKR is optimum, and you're on top of it. And over the time, assess plan your practice to know if the therapy is actually giving the result that you desire. Well, at this point, I'm going to rest. This is exactly what I intend to discuss with us. And let me rest here because of our time, and then we can continue with other things maybe some other day. Thank you very much for your attention. Appreciate it.
Thank you very much, Mr. Adedeji.